some audio problems. There we go. Hopefully that fixed the audio issue. I apologize. So just to repeat here, the purpose of the video today is to go through all the different structures that can be injected during a PICL procedure. I think there's still some confusion between anterior structures, posterior structures, what gets included, what's not included. In addition to that, we have a new form that'll get filled out and handed to the patient at the time of their treatment so they can know exactly what was injected. And I wanted to do a video that complements that form so that way, if there's any question that they have what the structure is, they can go home and watch the video. And it'll be this video. So a little bit longer didactic portion today, and then we'll get into questions. The questions, again, can be about what it is we're talking about today or really anything else. So let me go ahead and share my screen here. Okay, looks like that worked. And now we'll get the presentation started. Okay, so today we're going to be talking about what are all of the different structures that are commonly injected during a PICL procedure. So as you know, the PICL procedure is very specific to the type of CCI. And if you've been watching all of these videos, you know that we classify CCI into 8 different types. Type 1 involves C0, C1. Type 2 involves C1, C2. Type 3 involves C2, C3. And each of those types focuses on a different target to be injected. So what we do is highly specific, both in the diagnosis and the treatment. And that's reflected, as you'll see here, in all the different parts and pieces that get injected during a PICL procedure. So this is what this form looks like. This is a form that we'll be handing out to patients. We're having some difficulty with medical records requests. Everyone wanted their PICL documentation to try to see what was injected, what wasn't injected. So the goal of this form is to be able to hand it to the patient after the procedure. So here's exactly what was injected. Now, also on that form will be a web link to this video. And the goal there is so that patients can translate what's been checked on the form and better understand what actually got injected and why. So we'll start with the facet joints. Facet joints are small little joints in the neck. They're about the size of finger joints. And we use an X-ray guided technique with contrast confirmation. So what that means is that we specifically target a joint and then we confirm with X-ray guidance and radiographic contrast that we're in that joint. So that's using this posterior approach. So the needle is placed precisely into the facet joint, which is over here. And the 3 joints that we're most commonly injecting in craniocervical instability patients are C0, C1, which is this concave convex joint. The C1, C2, which is this biconcave joint, or I'm sorry, biconvex joint. And then the C2-3, which is more of a sliding joint. And so these are the 3 most common. Now we also inject other cervical facets as well. And this is based on physical exam. Now, we do not inject asymptomatic joints. So this means that the doctor has to do a thorough hands-on exam with you lying face up that identifies which specific joint is symptomatic and which joint will be injected. Now, if a doctor doesn't do that hands-on exam, palpating every single joint in your neck, then that's below our standard of care. And if a doctor just randomly decides that he's going to inject all the joints in your neck, that's below our standard of care, meaning that we inject symptomatic joints. We don't inject joints just to inject joints. And this is what it looks like. So these are not easy to perform procedures. This is a C2 here. This is C3. So this is the C2-3 facet joint there. That's what the needle looks like there. Now this one is a C0, C1, and this is a procedure that we've got more expertise on than anyone else on earth, meaning there's no one else on earth that's even a close second in doing the number of 0-1 and 1-2 facet joints that we've done. In fact, I do right now between these two joints, a few dozen a month. You'd be lucky to find a doctor that's done a few dozen in their entire career. Now, for this one on the right here, we have to use digital subtraction angiography to make sure that that's safe. So that means using a technology that allows us to see where the contrast is going. And we don't want to see it going into the vertebral artery. So to do 0-1 and 1-2 safe, we have to use this digital subtraction angiography. We can also inject the facet capsules, and we can inject inside the joint. A lot of times when that term facet capsules is used, it means the doctor doesn't really have the skill level to inject inside the joint. So they're putting the needle somewhere around the joint. That's not what we do. We specifically inject that joint. We specifically inject those facet capsules if they're needed. So if you had your facet joints injected, that's a small tutorial on what it is we did. And then this is just showing digital subtraction angiography, what the doctor sees when the injection is being performed. And now next we'll talk about internal upper cervical ligaments here. So you can see we've got them all listed here. These are ones that we would do during the PICL procedure. So these are all an anterior approach. That means that we have the 3D printed mouthpiece in. We're using an endoscope to keep a sterile field at the back of mouth. And then we're using dual axis C-arm fluoroscopy, meaning a C-arm going one direction and then another one simultaneously going the other direction to be able to have the accuracy to inject inside these ligaments. So here we're using radiographic contrast to make sure we're in these specific ligaments and all of that different equipment I described. So let's go over these. The alar ligaments, those are probably ones you've heard about. So they go up from C2 or the dens, and they head towards the skull. And they're heavily involved in reducing that side motion or that type 2B instability. Then we've got the transverse ligament, which acts as a seat belt for the dens, and you can see that here. And that's reducing that type 2A instability. So that's why we would want to inject those. Then there's also the accessory ligament, which gets injected pretty much anytime we're going after the alar. I realize there's two versions of alar. And this I'll probably have to draw a little bit to the side here. So we have the dens here, and that's at C2. And then we have the alar ligaments coming this way. And realize the alar ligaments are not really shown this way, but there's an upper sling portion that goes like this. So if we're going below the dens, we often end up about right there, or below the atlas. The atlas is coming across this way. So we'll end up getting into the accessory, which will bleed up usually into this lower alar. And so we'll get the lower alar and the accessory from that position. If we want to get this upper alar sling, we have to go above the atlas, and that's listed on the form. Now, a lot of times when we're initially treating patients and we don't know how they're going to respond, we'll just stick with the below atlas approach. If we believe the patient can tolerate more, we'll add in the above atlas approach. And then we've got lots of other ligaments that are on that form coming from the anterior side. So we have the SAAOL, which is just an extension of that anterior longitudinal ligament further up. We've got the AAOM, which goes from C1 to the skull. Then we've got the apical ligament that goes from C2 to the skull. Then we've got that transverse band of the cruciate ligament. Those are the same things. And then finally the tectorial membrane up front, which is the deepest ligament that's adhered to the front of the dura there. Now in the back, you'll see as I talk about these next that we have the posterior atlanto-occipital membrane there. We've got a VDL or vertebral dural ligament that lives between C1 and C2. And then we've got this deep ligamentum flavum that's below that, but I'll talk about that in a second. Then from the front, we also have this lateral AO oblique ligament, and that goes from the transverse process of C1 all the way to the front of the skull. And that's going to be heavily involved when you've got too much extension of the skull on the spine. And really all of these anterior structures are going to serve that function. They're going to be involved in scenarios where you've got too much movement occurring when the head goes back. Now that's in general. There are other ligaments that do other things, but in general, that's what we're talking about here. We can also do this anterior longitudinal ligament from the front, and we often take that down to C2-3 or below when there's a C2 on C3 retrolisthesis, meaning C2 is going backwards on C3. We can also hit these anterior facet capsules at C0, C1 here. Again, when we're seeing too much extension on the skull occurring. So that's going to be in a type 2B, or I'm sorry, type 1B. Let me write that down. 1B instability. So again, all of these ligaments are controlling various things when you bring your head back. So for instance, this anterior longitudinal ligament, if that's damaged at C2-3 down here, this is C2, this is where C3 would be, can allow too much movement backwards when you bring your head back. So that's going to be that type 3B instability if we got that area. Then we've got the posterior cervical ligaments. And so as we talked about before, the more superficial ligaments here are going to be things like the nuchal ligament. So we have here the nuchal ligament up top, the vertebral dural ligament next, supraspinous and interspinous ligaments below that. And normally we're hitting those pretty routinely in all PICL procedures. And those are going to be involved in things like a type 3A instability, where you've got too much motion of C2 on C3 inflection. So C2 is moving forward on C3. They have a secondary role in controlling that type 2A, which is going to be transverse ligament, but that's only a secondary role. And they may be important if we're seeing the skull sliding forward or a type 1C instability. Also realize that the deep ligament here, which is not on here, is the PAOM right there. So these are important ligaments in flexion type instabilities. Now, the good news is these can be reached without a PICL procedure, and they're often injected with a PICL procedure as well. Then we get into muscle injections, and we will inject muscles as well. Many times that's because we detect that there's overload in that muscle. And usually here, while we're injecting the other ligaments with bone marrow concentrate, we use platelet poor plasma. And we use platelet poor plasma because that's been shown to help muscle satellite cells proliferate. Satellite cells in muscles are muscle stem cells. So these are the ones that we would normally end up treating. Now, realize that we've got all the small muscles in the back of the neck here. And all of those small muscles, of those, a really important one for our purposes is this rectus capitis posterior minor, because that jacks directly into the dura and can cause headaches. So frequently we'll inject that one with its tendon. In addition, it's possible to inject the longus capitis or coli up front, and realize that anytime we do a PICL procedure where we're coming below the atlas, we're automatically getting that anyway on exit. And when we go above atlas, we are also getting that on exit. So that's often included, even though it may not be checked off. It's part of what it is we're injecting as we go in and out. And then we know these big muscles, right? We know the upper trapezius, or the trapezius muscle in general here is one that we can inject pretty frequently. We'll inject this levator scapula muscle, and we'll frequently inject the sternocleidomastoid if it's a separate problem. Then we've got tendon to bone attachment areas. And so these common ones would be where all of these muscles insert at the skull base here. Another one that's not uncommon would be where the sternocleidomastoid takes its origin here at the mastoid process. Then we've got nerve hydrodissection. This is also frequently done during a PICL procedure. Now remember, all of these are being done very specific to the patient. So physical exam, history, imaging, all determines which of this long menu that is called the PICL procedure gets done in any particular patient. But as you can see here, there's quite a few different nerves there. And one of the ones, these two here, I'm just going to call out right away. So what's being done there is we've got the sternocleidomastoid muscle that we can see on ultrasound imaging. It looks like that under cross section, and that's this big muscle up here, remember. So if those are checked off, it means that the little nerves that come out behind that go to the superficial cervical plexus, underneath that sternocleidomastoid, that those were injected with platelet lysate or growth factors that contain things like vascular endothelial growth factor, which can increase blood flow, or nerve growth factor, which can help with nerve repair. And under ultrasound guidance, that means we're hydrodissecting, or we are injecting around that nerve. Then more medially, if this is usually medial or really towards the front here, and this is posterior towards the back. We also can treat this vagus nerve complex as well if someone's got quite a few autonomic issues. So we can treat either one of those. Then, as you know, there are many nerves that snake through this muscle complex. And these are often nerves that cause headache. So the lesser occipital nerve can cause headache. The greater occipital nerve can cause headache. The third occipital nerve can cause headache. And these are often hydrodissected as well. So hydrodissection, again, means that we're precisely using ultrasound guidance to inject these platelet growth factors or a platelet lysate around the nerve. And then we've got auricular temporal, sometimes called the temporoauricular nerve, that kind of goes up into this area of the head, this temporal region, and that can be treated in addition to the occipital nerves. So there are other things that we commonly inject that are on the form, but these are the highlights of what gets injected 95% of the time with a PICL procedure. Now, again, this is a check off the menu based on the imaging, the symptoms, and the exam. So not everyone gets all of that injected, and we specifically tailor this to each person. But as you can see, there are a lot of different areas that can be injected during a PICL procedure. And then rather than providing a copy of the notes, we're going to be providing a copy of this form to let the patient know what was injected. And then this video will serve as a way for patients to better identify those structures. So let me go ahead and stop the sharing, and I'll go to answer some questions. Okay, let's see what we got. Got a bunch of questions here. It's been advanced by DB. Does everyone that has a PICL procedure get all their structures injected, or just the structures that are causing their specific symptoms? So good question. Yeah, again, it's focused on that particular patient and what's wrong with that person. And the type of instability maps to what needs to be injected. And then the physical exam and history also maps to what needs to be injected. So at the end of the day, we're only injecting a subset of that in each patient. Now, we've got a few patients that might get all of that, but that's pretty rare. Hello. It's been advanced by Jerry Schmidt. How long in advance are you currently scheduling PICLs? Any chance of ever doing these procedures in UK, France, or Belgium? I think there's no chance of me doing the procedures in the UK, France, or Belgium. And usually we're 2 to 3 months out, somewhere in there. Now, if we've got a patient that needs to get in sooner, we can usually accommodate that with a cancellation. So we've got cancellation lists. So we frequently have patients that get in sooner than that on a cancellation, but obviously they have to be more flexible. Ulysses, so the doctor has to feel the joint before the injection. Correct. Can you feel the C1, C2 joint? Yes, you can. You can feel all these joints. Now, obviously, in heavier patients, it gets harder to do. In thinner patients, it gets easier to do. But again, just realize that standard of care dictates that the doctor palpate these joints. So that means that you are lying face up on a table to relax those muscles. So you can't do this sitting down. And the doctor goes level by level. So for instance, I use a scribe. Carla is my scribe currently. She's being replaced as my scribe by a new scribe, but she can tell you, I will call these out: 0, 1, 1, 2, 2, 3, 3, 4, 4, 5, 5, 6, 6, 7, so that we can get an accurate map of which joints are symptomatic. We also know which joints to inject based on where the referral patterns are going, meaning we have referral patterns for each one of these joints. So we know, for instance, that the upper cervical ones go into the head, that the mid-cervical ones kind of go in the upper trap and shoulder, and the lower cervical ones go into the upper back. So all of that is taken into account in mapping out which specific joints need to be injected. Again, if you see a doctor that does a cursory exam and wants to inject C0 through C7, that's just bad medicine and laziness. Are there patients that need C0 through C7 injected? A few, but they're few and far between. So if you're seeing a doctor that's doing that a lot, they're just being lazy and not wanting to take the time to perform an examination or a proper examination of the neck. Stacy, can you detect symptomatic joints if our symptoms change hour by hour or day to day? Yeah, in general, yes. Remember, again, it's palpation, it's history, and the history is where the patient is hurting. So each one of those joints refers to a different spot. But if it's changing day by day, meaning if one day the right C2-3 hurts and the next day it's the left C6-7, and then the C2-3 doesn't hurt again for 2 weeks, C2-3 probably doesn't need to be treated, meaning that there isn't enough ongoing force in that joint to want to treat it. Liam, I've been doing very well since PICL2 a couple of weeks ago. Is a comment for symptoms being immediately better post PICL. Have that improvement last even when the procedure inflammation is gone. That's not uncommon. Now, if you have that response, it could be that there were other things causing a lot of those symptoms that were treated, and the anti-inflammatory effect of what we did is what is predominating right now. So let me give an example. Let's say your symptom was headache and it was due to the right 0-1 facet joint. In some patients, especially younger patients with less systemic inflammation, they might get almost an immediate anti-inflammatory effect of putting high-dose PRP into that joint. So they would feel better almost immediately, and then that would continue. Aaron, hi doc, recovering well for number 2 PICL 3 weeks out. Thank you for that information. Thanks for the update. Amin, I think, higher Centeno from Morocco. We don't have DMX or upright MRI. So I did X-ray flexion extension, open mouth, tilted, and the distance between the dens and C1 is asymmetric, but no overhang of C1. So if there's a couple things to unpack there. The first would be that we have to get a good amount of lateral bending. So for that to be diagnostic, and that's probably the first thing we see is we'll certainly see patients where they just didn't get enough range of motion to make a go of it. So assuming there's enough range of motion, then that would mean that you don't have type 2B instability. Now there's other types of instability to be looked at. But that's what that would mean, assuming we have enough range of motion to make a go of the whole measurement. Can AAI cause lack of blood flow to the brain, causing puffy and black under the eyes and muffed hearing and difficulty swallowing? It could. So we could certainly see intermittent internal jugular vein compression. So that can lead to some of the things that you're talking about here, or cranial nerve 9 irritation, which might lead to the difficulty swallowing. Also realize that the structures we're talking about are just behind the tissue at the back of the throat, or what we call in physician land, the posterior oropharynx. And there's only about 1 centimeter of tissue there to the bone. So if you've got instability at C1, C2, you can also get problems with swallowing because of direct irritation at the back of the throat. Amber Smith, I've had C71 injected, but also the sides of my neck injected, last 4 treatments. Are the side injections considered facet injections? Those side injections, the reason my atlas has stayed in place. I need to know a little bit more. So you can do an intra-articular facet injection from the side as well. That would be under X-ray guidance with contrast confirmation, meaning that it would be a real-time fluoroscope and they'd inject radiographic contrast to make sure they're in the facet joint. So I would need to know more about what it is they were doing. Now, if we're talking about the upper cervical spine, you wouldn't want to come from the side because that's where the vertebral artery lives. So you have to come from the back. So let me know some more about that so I can answer that question better. Progenics made advanced by Sherry Scott. I think it's Sherry Kopp. Does having EDS eliminate a patient from being able to get the PICL procedure? No, Sherry, I think we've talked about that a bunch of different times here. We did not see a difference between EDS patients and non-EDS patients. We've looked at that twice now. Now, I think it takes longer for EDS patients to recover than some of our non-EDS people, especially our traumatic non-EDS people. But there isn't a difference there or a contraindication based on what we're seeing. Stacy, can you use a non-propofol, I think, anesthesia for PICL? We cannot. So propofol would be essential, or we cannot perform the procedure. Liam, can the nerves that provide sensation of the skin of the neck become compressed due to CCI and not function properly? Since having CCI, posterior half of my upper neck skin feels numb most of the time, but during honeymoon phase of the same area felt very touch sensitive and alive and still feels healthy and more sensation, if that makes sense. Yeah, so if you're talking about the back of the neck, that's usually C3, and the back of the head here is C2. Everyone's wired a little differently. There certainly may be patients out there that have C2 at part of the back of the neck. Realize that that's not hard and fast, but that's generally where those dermatomes go, meaning spinal nerves go to the skin and have certain representations on the skin. So it's certainly possible with the C1, C2 injection, since the C2 spinal nerve lives in the back of that joint, that you may be getting the effect of the nerve growth factor on that C2 dorsal root ganglion that lives there. And that would supply the upper part of the back of the neck in some patients. Also C2-3 as well, that can leak into the frame and around the nerve. So that may also be doing that, or it also just may be a stability issue. But if it was pretty quick afterwards, then it's probably more a direct action on the nerve that goes to that area. Some advice by Sherry Kopp is occult tethered cord more common in patients who have EDS. Yeah, so again, I think, as most of you know, I'm not a big believer in the occult tethered cord concept. It's pretty controversial. I think it's poorly researched at this point. There may be some patients out there that need cord detethering, but I don't believe that you should get this before you do a PICL procedure, nor is it a first, second, or third line treatment. It's a fourth or fifth line treatment when everything else has failed. Now, is the concept of occult tethered cord more common in patients who have EDS? Patients that have a low CXA type CCI, so a type 2A, can get additional pulling pressure based on the work by Henderson et al. When their clivoaxial angle collapses or their skull comes forward. And so the theory would be that that's causing more pulling pressure and causing a occult tethered cord. But realize even that's a pretty controversial concept. So again, I don't believe that anyone needs an occult tethered cord release with a PICL procedure. That would be putting the cart way, way, way in front of the horse and exposing yourself to unnecessary surgical risk. AT, what's your opinion on CBP versus upper cervical techniques? I think CBP helps the curve correction. Specifically, if the other techniques were to rely on the upper cervical spine, particularly outlets and axis. Yeah, it's a hard thing because a lot of our CCI patients have a decreased curve. So CBP would be the answer. That's curve correction type treatment, chiropractic biophysics. Having said that, the upper cervical spine misalignment, almost all of them have. So I would say for most patients, starting with an upper cervical chiropractor would be the way to go, and then adding in curve restoration, if that's required, is a good next step. Liam, I have lost sensation in the area of my left palm and wrist, the ulnar side of the wrist and the hypothenar. I think it's ulnar tunnel, hypothenar hammer syndrome, Gans canal. The numbers developed after doing a lot of machining and constant pushing into my palm. Can this sort of injury be treated effectively with PRP? Restore sensation? Is this done CSC or other virginic locations? I saw Dr. Marco blog it a couple of years ago. Yeah, so a couple things to think about and consider there. The first is that, we would look anywhere along that nerve. So the C8 spinal nerve root, then the thoracic outlet, the lower trunk of the brachial plexus, and then the area here at the elbow where the nerve snakes through, the funny bone spot, if you will, and then finally Gans canal down here. So identifying where the compression is pretty critical in treating it, but it could be any one of those four locations. So you really got to get that pegged first. Assuming we've gotten that nailed down very precisely, then yes, any of those areas can be treated with PRP or platelet lysate. Obviously different types of treatments for each, but the idea is pretty much the same. Jason, off topic, but MRI machines seem to be not really be designed for diagnosis of CCI. Even the upright machines seem pretty lousy. Can you talk about the challenges, if any, posed by limited field strength and resolution of upright MRI when doing flexion extension? Maybe certain structures of interest are too small or fuzzy to see. I feel like medical imaging has a long way to go. Yeah, I think Jason brings up an important point here. We have two kinds of MRI out there, two different concepts. One is a closed bore, and that's where you go into sort of a hole and the machine is around you. And the good news about a closed bore MRI is it's higher field in general. And we tend to get much crisper, better pictures. Then we have upright machines where you've got the machine to the left and right, and you can see out into the room. And in those cases, you can do things like flexion and extension in most of those units. The problem there is that they're low field strength magnets, and some of them are reasonably good, and some of them are pretty bad when it comes to identifying specific structures. So listen, what I do is I focus on the strengths of each. So for movement-based MRI, upright's the way to go. You can get information off of that you can't get from a closed bore unit. But when it comes to identifying specific structures, if we really have a question about looking at a specific ligament, alar ligament, transverse ligament, PAOM, tectorial, etc., then a closed bore MRI would be better for that because it's going to give a sharper picture. And I would agree, all of these things have a way to go. I suspect that what we'll see here coming up in the next 10 years is not only some higher field strength magnets for open units, but we'll also see the addition of AI algorithms that probably are able to get more data for a better picture and clean up some of those artifacts that we see in the upright MRIs. But like anything else, those would be the newest, latest, greatest machines, which are probably going to be the most expensive. And, you know, we'll see another 10 or 20 years while the older machines wind their way through their life cycle. Ulysses, there are some doctors who feel the joints of the neck, then inject blind without any guidance. Yeah, that's just stupid. I hate to say it that way. That's just a dumb idea, meaning that you're just asking for trouble there. And I think in this day and age, in 2023, where guidance is so easy to obtain, and it's so easy to obtain the education on how to use guidance in the cervical spine, that blind injections, which is really what you're discussing, are below the standard of care. And what I mean by below the standard of care is the doctor is violating that standard of care and doing something they shouldn't be doing. They're increasing risk for the patient. But they're doing it right because it's easier for them. And that's a concern. Any doctor that would put your safety below their convenience or their price point, meaning they don't want to buy an expensive machine, they don't want to take the coursework to learn how to use it, I would run away from that doctor as quickly as I could. Stacy, which ligament most important for CXA continuing to go down? I'm down to 127 now, so Den's hitting my brain when Ben head forward. So there's a number of different ligaments. If you, Stacy, go look at the video that I have on type 2A, instability, or if you just type on the channel under YouTube and you go under lives there, go under the live section because it's not under the regular section, and search those lives for either 2A or CXA, you'll see that. And I go through those ligaments, but in general, it's some of the posterior ligaments back here, as well as usually the tectorial membrane, which can only be reached from the front, that are critical there. Now, we can also see other issues involved there. So a type 1A and a type 2A. But I think if you just go to the channel, type in CXA, that lecture will come up where it talks about all of that. It'll talk about all those different ligaments that are involved as well. Amin, is it normal to have symptoms this year knowing he had mild fall whiplash back in 2018? I was just 23 years old. Yeah, I think we certainly see patients that follow what I would call the straw that breaks the camel's back, right? Basically, what happens is that those patients get some sort of injury, the ligaments get irreversibly damaged. Then they get to a point where they're pretty asymptomatic, whether that's because they've structured their life to avoid certain things, or it just kind of heals, so it's good enough. But then as they get some age on them, eventually it becomes symptomatic, or something else happens that's the straw that breaks the camel's back, so to speak. Ulysses, is it impossible to inject the VDI in the neck too? I think you mean VDL, vertebral dural ligament. No, that can be injected. If the skull is rolling forward, what type is that again? So I think you're talking about low CXA, type 1A. I have constant pressure in the ears, difficulty swallowing, nausea, pressure in the head, and tight neck. Mild headaches are those typical of CCI or AAI symptoms. They can be, sure, but I would need to do a telemedicine to get a better sense of that. Ulysses, do all Regenetics clinics have PRP too? Yeah, all Regenetics clinics should offer PRP. Obviously not in the area that we're talking about right now, but in general. Ulysses, I heard the strong muscles help stabilize the neck when the small muscles don't work, and it also causes spinal imbalance like scoliosis too. Yeah, the large muscles kick in when the small muscles aren't working, and that can lead to all sorts of problems. Have you heard of an upper cross syndrome and upper body for instability? Yeah, that goes back to some of the work by Andres Vlaming, and it has to do with these cross patterns in the body. So, for instance, the connection from the latissimus dorsi on one side all the way down to the low back on the other. So these crossed patterns, that was all first discussed by a biomechanist by the name of Vlaming. How long is the PICL procedure? Depends on what we're doing and how much is getting done during the procedure. But we usually book 1 to 2 hours depending on what's getting done in that particular person. Regenetics, made advanced by Harry Winston. Can CCI affect your ability to know where you are in space? When I'm walking with someone, I keep bumping into them accidentally, which never happened before my neck injury. It certainly can, Harry. That's all the upper neck proprioception or position sense that gets impacted in CCI patients. Ulysses, don't forget to make a video about which type of needle. Oh, that's right, Ulysses. Thank you for reminding me. Hey, do me a favor, Ulysses, drop me an email on that one so I don't forget that. I'm going to put my email address down here. The email address that goes to my desk in the comments, but drop me an email on that one just so I don't forget about it. Is CCI or AI a progressive issue like it can get worse with time? You know, it can. We certainly have a percentage of people that are able to recover without anything being done interventionally. Then there are patients who stay pretty stable for a long period of time. And then we've got patients that worsen over time. I think more likely than not, if it's severe AAI, something like a 2B with a lot of overhang, those patients in general do deteriorate over time. And that's just most people. John, post-PICL is normal rotation, flexion, extension of the neck acceptable, good voluntary head rotation, ruin of PICL, how far are the ligaments in the early stage of remodeling? Unlikely that a voluntary head rotation could ruin a PICL procedure. Ulysses, a lot of people are starting to have CCI because of text neck, like the use of cell phones. I don't know about CCI, but certainly we're seeing more impact on the upper cervical spine from things like text neck. The right SCM must have been through a stampede. I don't know what that one means. Higher Centeno, which is more beneficial post-PICL in terms of cellular better healing, prolonged fasting, or high protein diet. I don't think prolonged fasting is a good idea. I think that's something short-term fasting you might do prior to a procedure. A high protein diet, meaning high protein, low carb, I think is a better idea. Amber, what are the side effects that occur when injecting above the ligament you mentioned attaching to the skull? You mentioned bleeding. Sorry, I forgot the name. I don't know which of the ligaments you're talking about there. There's a bunch of them above the skull. No specific side effects to date with injecting above this or injecting above the atlas versus below, which is what I think you're talking about. Jason, follow up in support of Winston's question. My mother has persistently had terrible proprioception for many years. After a car crash, no broken bones, but lots of weird problems that no one can fix or diagnose. Yeah, so that's a super common thing when the upper cervical spine is impacted or affected. Brian, would you ever go through the mouth intra-articular injection of PRP only into the median axial joint for a patient who can't utilize BMAC? Generally not, no. But Brian, I need to know more. I think I understand what you're trying to ask because I think I recall what you were talking about, bone marrow concentrate, but I don't know that I agree with you that there's a problem with your bone marrow. So that's a much, much, much longer conversation. Ulysses, can you still inject the joints that are subluxation a lot before seeing the AO chiropractor? Not quite sure what that one means. John, how can the ligaments heal without being immobilized when the already forced ligament prevented from healing? No, I think that's a misnomer. If you look at how ligaments heal, it's a little bit like dogs. This is an interesting concept. So if you look at the research on trying to immobilize animals, if you immobilize the animal, you tend to get healing that is less robust than if you let the animal do what it wants to do. So if you watch your dog after surgery, for example, your dog will go down hard for the first 3 to 7, maybe 10 days, depending on how much was done. But then they're back up and moving just as soon as they can. And the research shows that that type of immobilization, you go down hard when it hurts, and then you slowly do what you can within reason, results in better healing than immobilizing the area. Now, that's kind of counter to what many do in the orthopedic community. But I remember having this conversation with Wayne McElreath at CSU, who used a microfracture technique in horses. And when he was told by the human surgeon, Dick Stedman, that he should immobilize his horses, because that's what we were doing with humans after microfracture surgery, he laughed because you can't immobilize a horse. You'll kill a horse if you try to immobilize it like he was immobilizing humans. And the horses do as well or better with microfracture as humans do. So it goes back to that concept that the idea that you have to immobilize a ligament or a tendon in order to get it to heal is really flawed and not supported by the animal modeling that we have. It's just sort of medical tradition. Liam, thanks so much, Dr. Centeno, and your team for doing the PICL. It's made a world difference for me, and I'm very grateful. Thanks, Liam. I'm always happy to help, and always obviously happy to get that feedback. Thank you. Edward, for the minority of patients where PICL does not provide symptomatic relief or any objective improvement on repeat DMX or any logic in trying the adipose stem cell-based PICL instead of BMC. No, that one wouldn't make sense, meaning that BMC would have a more powerful effect on the ligaments than adipose tissue would. And there is no such thing as adipose stem cell-based PICL, meaning that we're the only people on earth doing PICL, and we don't inject adipose tissue in that area, primarily because of the lack of research for adipose tissue used around the spine. So no, I wouldn't do that at this juncture, nor would it make sense scientifically. Tanya, is there a solution against calcification, ossification of the alar ligaments? Not sure what you mean there. Do you mean that you're getting calcification and can that be fixed? I need to know a little bit more info. Oasis. I saw one of your video of how to read your MRI of the knee joint, a full thickness tear of the ACL, resulting bulking of the PICL. Which grade of tear? I need to look at your MRIs to see that. I obviously can't do that off that description, but certainly one of the clinic physicians can give you an idea whether or not you're a candidate for that kind of procedure. I know that we're talking about Italian there, but my Italian isn't good enough to read that. I mean, Dr. Centeno, do you know of any doctor in UE that knows about CCI? I do not know anyone there. Edward, someone has a real C1 articular facet injection. Does that mean that the capsule has already been exposed to a biologic, considering the joint moves around so much? Certainly the interior of the capsule would be exposed to the orthobiologic in that situation. Jason, hypothetical question. Suppose a man fell off a roof and broke his ribs. Let's say that 20 years later, suddenly develops dozens of neurologic problems associated with CCI, but has no neck pain. Is it possible ligament damage that occurred in the past has suddenly produced latent presentation of illness? It's possible. We would put that person in a typical presentation, and we'd probably need a little bit more information to get a sense of which end is up and why we would want to treat that person. Amber, I apologize. I don't really know the technical specifics. They entered below the ear and slightly forward. It was not at the C0 level. Yeah, Amber, I need to know more. Edward, if one does not get a honeymoon phase from a procedure, does that mean has no inflammation was created and the procedure won't work? Doesn't mean that at all. Finn, would a low CXA cause compression of the IJVs in vagus by the anterior soft tissues at C1 or past styloids or elongated? Generally not. It wouldn't be a low CXA that we'd be concerned about. It would be more rotation at C1, C2 or type 2B, or sliding forward of the atlas would be the two most common things, but generally not a type 1A low CXA. Jennifer, I'm pretty sure I'm going to need the PICL, but it's really hard to get an appointment with you. Yeah, Jennifer, obviously I'm always happy to help. First step would be calling the call center and just getting on a telemedicine. Did 5 of those this morning, and we always have cancellations, as I was discussing. Stacy, I get hives from glycerin-based products, and I got hives on face arms after a posterior injection with Dr. Williams from propofol, but must get my August scheduled PICL. Yeah, so Stacy, we generally use Benadryl for a lot of patients that have mast cell disorders or similar issues. So that's pretty common for us, but can't be done without, Stacy, can't be done without propofol. That wouldn't be safe. Finn, is there any diagnostic nuance between CXA changes in specific postures? For example, would a low CXA in extension mean anything more than a low CXA in neutral alone? Usually it's the other way. So a low CXA in flexion is important to understand, or a high CXA in extension. Finn, how successful is posterior therapy for increasing CXA? Are there other ways of increasing CXA? Finn, I don't think we want to increase CXA. We want to reduce the decrease of the CXA with flexion. You can certainly try posterior injections that are very specific as a first type of treatment for that. Ultimately, in many of those patients, we have to get the tectorial membrane from the front, but it's certainly worth a try from the back or starting there. Jason, blue sky question. Seems like in many diseases, stopping cause and effect is very difficult. For example, neck curve correction. Is there hope of disentangling the two for CCI research? Well, certainly Jason, that's why we use a multi-part diagnostic. So I think, as I always say here, we try to make sure the symptoms match. We try to make sure the imaging matches. We try to make sure that response to treatment matches. We try to make sure that the exam matches. And if all those line up, then we have a high confidence that we are dealing with something, and that, let's say, increased C1, C2 overhang is leading to that person's symptoms. If we only have one of those that lines up, we have a very low confidence level that the two are connected. For every young, we're the chance of detecting AAI if we compare DMX and CT, CBC rotational scan. DMX would have the highest likelihood of detecting CCI if present. A CT would be a very low likelihood of detecting CCI if present, about 1 in 100, regrettably. And a CBC rotational scan is not going to detect CCI at all. Donna, Dr. Centeno, I had telehealth consultation with you on May 23rd, and you need an MRI before you can complete my diagnosis. Caller confirmed receiving necessary images on June 12th. I've been waiting since then to see if I'm a candidate for PICL. Can I get a response from Carlos so I know how to proceed? Can you help me get some information on whether I have CCI or not? Yeah, Donna, why don't you just send me an email directly? My email address, I think I put here. I'll put it again here. So send me an email directly, and I will look into that for you. So I just put my email address in the comments. Yeah. So take a look at that. But email me directly. Forever Young, is the Dvorak paper the only one that looks to CT rotational for instability? Some neurosurgeons use other numbers to make their diagnosis. Yeah, the Dvorak paper is the only one that looks at two populations. So the Dvorak paper would be the only one that's valid, meaning that in order to have a number that's normal or abnormal, we have to look at how often that number or that cutoff is found in normal people versus people with the disease. And it's only that way that we can look at things like false positives and false negatives. So there's only one study that I know of that looks at C1, C2 rotation with those two populations. That's Dvorak. Now, if neurosurgeons are using other numbers, they made those numbers up, meaning that without that kind of normal, abnormal study, those numbers aren't valid. And in addition to that, CT rotational has another problem. It's 100 chest x-rays of radiation. So not only is it a low chance of getting to a CCI diagnosis, 1 in 100, it's also an immense amount of radiation to expose someone to try to get there when there's other tests that don't expose patients to nearly that amount of radiation or no radiation, like an upright MRI. John, with the application of IC hot impact infection with PRP a week after the injection. I don't think anyone knows the answer to that one. Donna, I've sent 3 mails since June 12th. I got that. Donna. Yeah, so send an email to me directly, Donna, and hopefully I can help you there. Is marijuana known to affect healing from regenerative medicine? There's one study that shows that THC can impact bone healing through mesenchymal stem cells. But no one's 100% sure to answer your question. What it will do is dramatically impact your anesthesia requirement, causing you to need much more anesthesia and increasing the risk of any surgical procedure, including this one. Stacy, do you advise a phone consult a couple weeks before PICL? Should I schedule or will the clinic call to set this up? Not sure what you mean, Stacy. Usually we follow up over email to see if we want to go forward with a second one, and then we follow up on the day that you're here. That's usually what happens. McCartney, are there any facilities in San Francisco Bay Area that do DMX or upright MRI? I don't know the answer to that one. Carla would. John, before Regenix had anxious, nausea, dizziness, shortness of breath, neck pain, Couldn't track my neck without severe pain, memory loss, MRI Blvd bulge disc. After my Genix PRP are now 8% better and getting better week. Thanks for Genix. Hoping my second injection get me to 100% able to run again. Nice to hear, John. Thank you for that info. And guys, I'm going to start wrapping this up because I do have a 2 o'clock and it's 2:01, 2 o'clock meeting. So let me see if there's any questions here that I haven't gotten to. Why don't you think prolonged fasting is a good idea? Because prolonged fasting would lead to malnutrition. Short-term fasting can actually help clean up inflammatory markers, but long-term fasting, not a good idea. John, do you expect to see what's done in Cayman to be made legal in the U.S. anytime soon? That's a good question, John. That technology is in a phase 2 trial currently, but that's still a long way getting through phase 3 and then a full FDA approval. Why is CRNA used to administer the PICL instead of fellowship trained board certified anesthesiologist MD? We could do that too. Realize that I'm a physician and the CRNAs have been trained how to do this, but we could use a fellowship trained board certified anesthesiologist as well. I don't know if they do any better job, but that's possible. It just would cost a lot more money. So probably add about 5,000 or so, 4,000 onto the cost of a PICL. But if you want that, that can certainly be done for sure. Do you think there's any role for pumice in modern day regenerative medicine? I don't. I think that's some old crazy stuff. Let's see, guys, I got to get rolling. I'm just looking through all of these questions, trying to see if there's something I haven't talked about before. Okay, and then I think I'll stop with this one, Chris. So long-term fasting, in this case, something that I envision more like weeks or months. Obviously, that's not going to work. Short-term fasting would be fasting for a day or fasting for part of a day or fasting for a day or two. Short-term fasting can be very helpful. Long-term fasting would be counterproductive to healing. Okay, guys, thanks so much. I'm probably going to redo that video sometime this weekend. So there'll be this version in live, and then there'll be one on the regular YouTube channel. The goal here is to try to make sure that everyone has a resource they can go back to that specifically allows them to say, aha, this was checked off on my form. Hence, I have some idea now what that means. So thanks so much for watching. Everyone have a great weekend, and I will be here on Monday. Maybe I'll do that needle size thing because that's an interesting one that Ulysses had recommended. Thanks, guys.